Good afternoon, everyone, and thank you for taking the time to be with us today. I'm going to go through what's happening on campus just before we get into all of it today. So what's happening on campus, we're excited actually to bring our Columbia community together for a moment of learning and connection by highlighting two upcoming events, the annual Walk-in Flu Fair and the New York City Marathon Step Challenge. And to get a flu vaccine, please visit the Morningside and Manhattanville campuses on the dates shown. And you can visit health.columbia.edu/flu for more details. And of course, get your steps in this fall by joining the New York City Marathon Step Challenge starting October 6th to Sunday, October 26th. The Step Challenge is a great way to connect with your colleagues, and please register by October 2nd. And we'll put the information up on our See You Thrive site and perhaps in the chat if we get a chance, but we hope to see you at the events. So without any further ado, what we're going to be covering today's session is we're going to be exploring the science behind obesity and metabolic health. We're going to be explaining how GLP-1 medications work, addressing common myths and misconceptions, and discussing lifestyle strategies for long-term wellness. And of course, thank you so much. I actually can't stress enough how excited I am to have two of our expert panelists here today from Columbia University's Irving Medical Center. So first, I would like to introduce Dr. Sabrina Diano. Dr. Diano is the Robert R. Williams Professor of Nutrition, Director of the Institute of Human Nutrition, and Professor of Physiology and Cellular Biophysics at Columbia University's Medical Center. She is also an adjunct professor at Yale University's Department of Cellular and Molecular Physiology. And she earned the Doctor of Biology degree and PhD in Physiology and Neuroendocrinology at the University of Naples, the Federico II in Naples, Italy. She became a faculty at Yale University in the year 2000, where she quickly moved up through the ranks, and in September of 2020, she moved to be here with us at Columbia University to direct the Institute of Human Nutrition. Her research is at the intersection of neurobiology, metabolism, and aging. And at Columbia, Dr. Diano leads a multidisciplinary research program that investigates how the brain regulates energy balance and metabolic health, with a particular focus on the hypothalamus and its role in aging-related metabolic decline. Her studies have been published in high-impact journals, including Nature, Science, Cell Metabolism, Diabetes, and her research program has been continuously supported by the National Institute of Health, the NIH. Her research has been nationally and internationally recognized, and she has been awarded the Novo Nordisk Foundation Laureate Award in Denmark. And she is also the recipient of the Helmholtz Diabetes Award from the Helmholtz Society in Germany, and her studies on the central control of glucose metabolism. She has also been recently elected as a Fellow of the American Association for the Advancement of Science. And at Columbia University, Dr. Diano directs the Columbia Cornell CME Obesity course, which is a continuing medical education program designed for healthcare professionals seeking advanced training in the diagnosis, treatment, and the management of obesity. So thank you so much for being with us today.
Thank you.
And Dr. Judith Korner. So Dr. Korner, she's an MD, PhD, and is the Professor of Medicine in the Department of Medicine and Division of Endocrinology and Metabolism at New York Presbyterian and Columbia University's Medical Center, where she's also the director of the Metabolic and Weight Control Center. Dr. Korner received her undergraduate degree from Barnard College and her medical degree from the College of Physicians and Surgeons at Columbia University, where she also obtained her PhD in biochemistry and molecular biophysics. She completed her internship and residency in internal medicine, served as the chief medical resident, and completed her fellowship in diabetes, endocrinology, and metabolism at Columbia University's Medical Center. Dr. Korner is a board certified in endocrinology and is the chair of the American Board of Obesity Medicine Board of Directors. Dr. Korner's NIH-funded research is focused on pathophysiology and the treatment of obesity and type 2 diabetes, really with an emphasis on the mechanisms of weight loss and improvement in glucose metabolism after bariatric surgery. She has published original research papers in addition to reviewing articles and book chapters on obesity. So again, thank you so much for being with us today. Now let's jump into really understanding obesity, like from the basis of all of this. and metabolic health. So I want to start off with Dr. Diano. You know, as a society, we're so fixated on this discussion of weight. So can you tell us, or what does it mean for our bodies to be overweight or obese? And what are the health implications that, we don't often discuss?
So thank you again for having me today. And so when we talk about weight and the way to um, uh, describe if an individual is overweight or has obesity, we looked at a specific type of a measurement that's called body mass index, which is a term that is utilized really to look at the weight of an individual. Unfortunately, the BMI, as it's called, is not a precise way of measure our, the fat mass specifically in our body, and because it doesn't account for the muscle mass or even the fat distribution, which plays a very important role in our metabolic health. According to the BMI, an individual can be categorized as overweight if the BMI is between 25 and 29.9, and over 30, there is obesity, is characterized as obesity. As I mentioned, all of these parameters, considering the fat mass is the very important measurements actually for our body weight, and specifically the percentage of body fat, but also the localization of the fat. Because when the adipose tissue and the fat mass is mostly visceral, and so surrounding organs, that is when our metabolic health can be and will be affected. And so many of the dysfunction can occur in our body. And so it can have, complication like cardiovascular diseases, type 2 diabetes, and so many other dysfunctions that can occur. So this is these are unfortunately the health implication that can occur with an increase in body weight in general and fat mass.
And Dr. Korner, do you have anything you'd like to add?
Yeah, I think it's the idea of extra fat in our bodies. It's just not an inert substance. I mean, we used to think of fat as just, sitting there doing nothing. But I think what we've learned more recently is that fat is a very active tissue, and that it secretes a lot of different hormones and different factors, such as inflammatory markers. And that extra inflammation is, part of what's causing increase in disease states. Probably also, I mean, we think typically of heart disease, but there may also be contributions to developing cancer, for example. And the distribution, as Dr. Diano mentioned, is very important, so that the fat around the waist, there's this sort of apple versus pear, so that if you are apple, the you're rounded and there's more fat around the waist area. That is where the increased inflammation and organ dysfunction will be more apparent than if someone has more of a pear-like distribution, where the weight is more centered in the hips and buttocks, really.
Oh, thank you. Thank you for explaining that, because even hearing you say that fat, has, as you described it, I don't want to say living organ, forgive me in how you phrased it, but the way that like fat changes like our way our body moves or metabolizes, just the hormones, everything. It's just really fascinating to think about. So can both of you bring us through like what is metabolic dysfunction or metabolic disorder? Because I think a lot of those terms are thrown around and most of us are just thinking like we barely know what metabolism is, but can you kind of walk us through like what is the difference for the two or where they intersect?
Well, if I can start, so we talk about metabolic dysfunction when our body can't properly regulate key biochemical processes. So they are important for energy production or energy storage and energy utilization. And when these processes are impaired, then can lead to metabolic disorders, such as obesity, type 2 diabetes, the metabolic syndrome in general. And so, and when these processes are disrupted, that's when that's when all of these disorder can occur, which have a lot of different implication for our health. As Judith said before, for example, obesity has a high association with type 2 diabetes, but also specific type of cancers, and therefore, the whole organism is basically affected.
Anything, Dr. Korner, you'd like to add?
Yeah, I think that we look at the scale and we focus on a number, and you have to put that into context of the whole person. So someone can have excess body weight, but metabolically, maybe things aren't really that unhealthy, and someone can even be within maybe a slight overweight range, yet metabolically, they can be unhealthy. So, yes, there should be a focus on the scale, on the BMI, but we have to look at the whole person in terms of their metabolic health. What are the cholesterol, the blood pressure, whether there's diabetes and heart disease, and look at the whole picture.
Yeah, thank you both for that. Absolutely. Like the things that preventatively we can look at from our labs too, and not to always judge a book by its cover, because internally things we don't know, right? By just looking at someone. So that's very important to denote. And can you walk us through like how do conditions of obesity or even prediabetes or a metabolic syndrome even develop in individuals? If Dr. Diano.
So yes, so this when we think about this metabolic dysfunction, we need to understand that this condition usually develop through a very complex interplay between our genetic and of course the environment and our behavior. So there is an important genetic component that has a profound influence on our metabolism in general, but of course the environment, our behavior, and just to say, the amount of food that we eat, if we have a sedentary life, these are all factors that strongly contribute eventually to the development of these disorder. And so, as I said, the excessive calorie intake is not only about how much we eat, but also what we eat, the quality of the food that we eat plays a very important role. And so if we have an excess of calorie intake combined with, let's say, a low physical activity, we're going to be in what we call a positive energy balance. So that means that we're going to start to store all of these energy in the form of adipose tissue, of fat. And especially again, if we go and we start to store this fat, specifically the visceral fat, that will have a profound effect on our metabolic health. It's a very complex interplay from genetics and behavior and environment.
Yeah, absolutely.
Yeah. I think also what, Dr. Diano has said, the quality of the food that we eat is really important. So it's quantity. I mean, you could actually eat healthy, but if it's too much, you're going to be in energy excess and gain weight, and that's not good. But you could also eat less, but if the quality is high in saturated fats or highly processed foods, that's not good either. So it's the amount and also the quality.
Yeah, thank you for that. And so can you tell us a little bit about what are early signs that we should be looking out for in terms of metabolic health that we should, watch for? Because as you mentioned before, a person may not be, overweight, but may be suffering from poor metabolic health or the starting of it. So what are some early signs we can watch out for?
Yeah, so I would say that certainly a lot of these signs are not really manifested physically. You may not know that they're there. So it is important, when you get a regular checkup, that also there are blood tests just to make sure that blood sugar is within normal, that it's not inching up, because there's normal blood sugar, there's diabetes, but there's an in-between, so what we call pre-diabetes. So that's a sign that really, it's a caution, that you can change the course of this disease process, where things are actually still reversible. Things like fatty liver, that's becoming more and more prominent and is a cause of cirrhosis, end-stage liver disease requiring liver transplantation, can put people at risk for liver cancer. And you're not necessarily going to feel that, but sometimes there can be signs of that in a blood test. Other things, that can go unnoticed are other things like obstructive sleep apnea. In people who have excess body weight, that can affect the quality of sleep, but also the amount of oxygen that gets into the lungs. And long term, if it goes untreated, it can cause heart disease, lung disease. And basically, you don't really feel well when you're not getting enough oxygen during the night, or you have awakenings that you might not realize are ongoing. So those are things that, there are certain signs for that. And if there's snoring, or you kind of find you're waking up out of breath, or you're sleepy during the day, those can really be all signs of metabolic dysfunction, that aren't the typical things that we think about and should be addressed.
Thank you. That was actually really important, because now you mentioned something about liver cirrhosis, that we might not feel it. So let's say we're going into our regular doctor's visit, that once-a-year visit that I hope you're all doing. What are the types of things that we might need to ask for, aside from our basic blood draw, especially like for the liver? Is that something we need to request, or is that part of a standardized test?
It's part of the standardized
Okay.
test,
Okay,
in
great.
addition to, and you don't necessarily have to have an abnormal blood test to have like fatty liver, but there are other things to think about, if someone has high triglycerides or high glucose, or, those are things that may need to be checked.
Thank you. That's so important because most of us, we get our paperwork back and sometimes the doctor will flag things and sometimes it's like, here you go and you're on your way. So thank you. So for all of us to advocate like for our our health there. So now really understanding like the science behind, suffering from obesity or overweight or metabolic disease or dysfunction, a lot of us here are really trying to think through. We hear so much now on GLP-1 medications and how that now plays a role into like the science of medicine and weight management. So what are GLP-1 medications for like me as a layman's person? Like what are they and how do they work in the weight management space and with metabolic health?
So the GLP-1 medications are basically a class of drugs. They mimic the action of a hormone that we produce that's called glucagon-like peptide 1 or GLP-1. And so this is a hormone specifically that is defined as incretin. So the main function is to induce the secretion of insulin. So whenever we ingest our meal, the intestine will produce and release this hormone GLP-1, which function to target one specific target is exactly, as I said, pancreas induce the release of insulin so that we can regulate our glucose level. And so that's how originally actually this drug were developed to really address diabetes. But then to realize that these drugs also are able to control our body weight, which is done through several mechanisms. Now, important to consider, GLP-1 is not only produced by the intestine, but it's actually produced by the brain as well, a particular area of the brain. And from there gets these neurons that produce it, can project to different part of the brain again, and in part regulate our behavior. Now, different that GLP-1, which endogenously in our body gets fast degraded. So the action of GLP-1 usually is very short. These drugs are resistant to degradation. And so they can actually act for a longer period of time, inducing, for example, insulin secretion, but also can penetrate the brain. And in the brain, we have a lot of receptors. So this ligand basically can bind to the receptor. And through this mechanism, they can regulate our food intake. So GLP-1 is actually what we define as anorexigenic hormone. So decrease our appetite and food intake. And so through this action, it can actually regulate, in part, of course, body weight. It also lower the gastric empty in our GI tract. So there are several mechanisms of action, but most importantly, they affect appetite through a mechanism that is in the brain, and the hypothalamus and the brainstem are the two main area of action of these drugs, where you have a lot of expression of this receptor, and this drug can act, bind to this receptor and induce this anorexigenic effect.
And we're going to talk through in a little bit, like navigating kind of the controversy, everything we've been hearing in the news in a little bit. But I do want to ask, especially Dr. Korner, who is considered a good candidate for GLP-1s and who might not benefit from them? Because right? We have everyone going, oh, we hear a lot that, I forget what the stat was, like 1 in whatever people that we know are taking them. So who would you say is considered a good candidate for them?
Right. Well, when someone is trying to lose weight, you don't automatically say, hand me a prescription. I want to inject myself, subject myself to potential side effects. Um, just do that. It's usually when people come to wanting or needing a prescription, they've often tried many diets. People come to our office and they've tried a whole bunch of different diets. They've tried to change their physical activity. And oftentimes, they succeed quite a bit, but then the weight comes back. And there are, which we don't have time to go into today, there are physiological reasons why the weight comes back, why it's so difficult to keep weight off. So I think when someone has tried and either they've succeeded but still need to lose weight, or they keep cycling up and down, that's time to consider a medication. And there are certain criteria that we use, mostly based on body mass index that Dr. Diano described. So if someone has a BMI of 30 and above, they are considered a candidate for medication. Or at a lower BMI, if someone has a BMI of 27, which is in the overweight category, but they have health consequences of extra body fat, such as hypertension or heart disease, sleep apnea, diabetes, etc., then we feel that we should really be a little bit more aggressive. And those are the people who we really would consider prescribing the medication for.
And I'm also curious, are there other medications that patients should discuss with their doctor or a healthcare professional before even perhaps attempting a GLP-1 in the categories you just described?
Well, one of the first things that we do is we actually look at a patient's current list of medications, what medications that they may be taking for other indications, because some medications can actually cause weight gain, or they can make it more difficult to lose weight. So for example, some antidepressants or antipsychotics or medications for seizure control or blood pressure, or steroid use. Those are medications that may cause weight gain. Now, of course, we are not saying you shouldn't be on those medications, but there are different classes. So if possible, if you need seizure medication or an antidepressant, maybe to talk to your own practitioner about which ones may be more weight neutral. So we first look at what people are already taking. Then most people will be able to take GLP-1 because there are very few contraindications. They really don't interact with other medications. Like there are other FDA approved medications for weight loss, but a lot of those have certain contraindications. So we do tend to think of the GLP-1 medications as first line therapies. But then we run into sometimes insurance coverage issues, and they are very expensive. So that's when we maybe start thinking about some other medications that are approved, but may be covered, or they may be in an affordable range for individuals. Or sometimes people don't tolerate the GLP-1s, and then we should think of the other medications.
Perfect
Yeah,
sense.
to this point, I think the side effects sometimes are the one that do not allow people to stay, for example, on GLP-1. And one of the stronger side effect is the nausea and the vomiting that can induce, which is all associated with the effect of GLP-1, these drugs in the brain, specifically affecting areas of the brain that regulate these type of function. And so the same area of the brain when that induce the same nausea and vomiting when we eat spoiled food are the same areas that would be affected by these drugs. And so often a patient won't be able to stay on this medication because of the side effect. So it's not a drug that necessarily works on everyone.
Thank you. That actually kind of leads us into my question on, what are the biggest myths or misconceptions about the GLP-1 medications?
Right. Well, if you go on Dr. Google, you will find many myths, many misconceptions. And, I think, one of them, for example, is Ozempic face, right? That we hear, oh, if you take it, you're going to lose all the fat in your face and you're going to lose too much weight and you'll look drawn and terrible. Well, that conceivably can occur, but that is if the drug is used improperly. So if someone has not that much fat to lose to begin with, and they maybe are improperly prescribed the medication, of course they're going to lose fat in the face and will wind up with so-called Ozempic face. We have control over this. Let's say someone is losing weight maybe too quickly or too much weight. Then we cut back on the dose. And that's why, we see people regularly to monitor to make sure that, they're losing weight in a healthy way. The other, talk about, losing weight in a healthy way. There's a lot of talk these days about losing muscle mass. And, that's an important consideration because when you lose weight, you lose both fat and muscle. I mean, ideally, we'd like to really lose all fat. But that's not something that's unique to GLP-1 medications. Even if you lose weight with a diet, you're going to lose fat and muscle. And the question is, when does that become concerning, that you're losing too much muscle? If you have obesity, you usually have not just excess fat, but you also have a lot of muscle. So when you lose some muscle, you're still usually left with enough muscle to keep you strong. But having said that, there are important things that patients should do while they're losing weight to kind of decrease the amount of muscle that's lost, such as making sure you're taking in enough protein, doing weight training, resistance exercise. So that will help keep your muscle strong. But what is lost in all of this controversy is muscle functionality, okay? So that just looking at the amount of muscle and saying you've lost it may not necessarily be a bad thing because you're also losing fat within that muscle. And maybe the muscles they're less, but they also function better. And they may function better because you're moving more. You can do things you couldn't do before. So I think those are myths. The other thing that I would like to stress is patients say, I don't want to be on this medication because I have to be on it forever. I don't want to take a medication that I have to take for the rest of my life. And I think that's really an important thing to talk about with with our patients, because they may be on other medications like an antihypertensive. When their blood pressure went high and the doctor said you need to take this medication, to lower your blood pressure, generally people don't think, well, I don't want to take it because I need it for the rest of my life. They say I need that medication. And then when the blood pressure is normalized, the doctor doesn't say, okay, your blood pressure is normal now, let's stop the medication. I mean, that just doesn't happen. And I think we need to think about weight loss medications like that, in that there's a reason, as Dr. Diano said, why someone might have a certain body weight, whether it's genetic or whatever that might be. And the medication will work while you use the medication. It's changing the signaling. It's decreasing hunger, increasing fullness. When you stop the medication, the wiring is going to go back to where it was. And there's a very high chance of weight regain. Not everyone will regain the weight because you may change what you're doing for fitness or how you're eating. But the idea is that it is quite possible you may need this medication as a chronic medication.
And to this point, exactly as Dr. Korner said, we need to think of obesity as a chronic disease. Is a disease. We know that we have a lot of evidence. It's not just the lack of willpower. It's a disease in which actually the brain plays a very important role. And as a chronic disease, you need to have a chronic type of approach for its management. And so a chronic medication is the way, in the same way as Dr. Korner said, we treat, they treat the high blood pressure.
Thank you both. You actually had me thinking of a lot of different questions there with what came out of that your response. So thank you so much for that. And I'll actually ask the one that, again, we're talking about the controversies, but what are the concerns, right? Because with the people that we're talking about that may suffer from obesity versus those that are using GLP-1s like for cosmetic weight loss rather than for actual medical necessity. What are, the concerns around that?
Well, I mean, there is concern if, you're using it more cosmetically because, you want to get into clothes that you wore 20 years ago, even though you're not necessarily, in the so-called obese range. You will lose muscle along with the fat. And particularly, we lose muscle as we age as a natural process. And that's not healthy either. I mean, we want our muscles to be strong and healthy. That helps with balance, strength, which will help prevent falls, which are really dangerous as we get older. So and it's called, sarcopenia, which is really when you lose too much muscle. So it really then becomes a concern if used improperly.
Thank you. Because going back to an earlier point you made, so are these medications meant as a lifelong solution, or you were mentioning with when you're on medication for like hypertension, is there a strategy like for transitioning off them safely?
Right. So that's a great question. And other than weight, okay, there's a lot of other health information that we are learning about some of the health implications from these medications. So, for example, one of the medications, semaglutide, also known as Ozempic or Wegovy, has been shown to decrease in people who are at risk for cardiovascular disease. There's a 20% decrease in the chance for another heart attack or a stroke or death from cardiovascular disease. That's huge. That is very huge. So, and some of that, okay, you might say, well, people are losing weight, so of course there's going to be decreased chance of this, but some of it is believed to be weight independent. So the medication itself may also have effects on the cardiovascular system that protects it from, stroke and heart disease. There are also, one of the medications, tirzepatide, is now approved for obstructive sleep apnea. Okay, so individuals who have that, I talked about that before, and have to use, whether they're using, a breathing device or not, symptoms of obstructive sleep apnea improve. There's also looking at liver disease, whether, kind of the precursor for further liver disease, fatty liver. If you lose fat from the liver, that makes you healthier. So other than weight, there are other reasons why one may want to continue and stay on these medications. The question you ask is an interesting one, in that, do you stay on the same dose? Do you decrease the dose? What happens? And I think that has to be individualized, because we know that the vast majority of individuals will regain weight. Do they regain a little bit of weight, part of the weight, all of the weight? We don't know that. The question, the important thing is that if you were going to consider coming off the medication, that you do so slowly and you do so in a stepwise fashion, so that you could monitor what is changing. And then if you see that the hunger is coming back, you need larger portions, you may need to go back on the medication. But we don't think that that is necessarily a negative, a long-term problem. Now, granted, can we guarantee that 20 years from now we don't uncover that long-term use may be associated with some issue? There's no guarantee of that. But right now, it seems that for the most part, it's advantageous, not just for losing weight, but for other conditions that may be exacerbated by increased weight.
Yeah, one thing to consider is this medication are relatively new. We don't have long-term studies on that. And so just a few years, we can see all the beneficial effect on different metabolic disorders, but we don't really know yet really the long-term effect of using this medication.
Thank you. Thank you both for that, because you kind of answered in your responses to the other questions, like the possibility of long-term benefits of the medication, and of course the possible long-term effects, which again, we won't know until time keeps moving on. So looking at the time, let's jump into our lifestyle and alternative questions. So how does improving our overall metabolic health really impact our energy, our mood, or even our long-term disease risk? Dr. Diano, if you want to start us off.
So definitely, we know that has a very improving our metabolic health has a profound effect on all our, on all body, and also, on the brain per se. So the mood, our mood changes, and with the losing weight, and there are physiological reasons for that. So it has a very complex and positive, let's say, outcome on our metabolic health. And there are very strong, physiological processes that important ones that are the basis of these changes.
Yeah. With regard to mood, this is a little bit different than mood, but maybe people have heard about the expression food noise or food chatter. Many patients will find that the medications sort of decrease this food noise and food chatter. And what they mean by that is, that there are always these constant thoughts about food that aren't really there because of hunger. Have breakfast and then you're thinking about lunch. You're having lunch and you're kind of thinking about having a snack, or what's in the refrigerator, or and that can be very, very disturbing. For whatever reasons, and I have to say we don't understand it, that oftentimes these medications just seem to decrease this noise and chatter, and people find it as quite a relief.
And can you walk us through, what are some of the most effective, maybe non-drug related approaches that we can improve our metabolic health and even, trying to manage our weight sustainably?
Sure. And I really would like to stress that these medications are not to be used in a vacuum, in that they are to be used if to get the most effective and healthy results. They are to be used with what we call lifestyle changes. So it's important to have a healthy diet, to get enough protein, to get enough calcium. As I said, decrease the amount of processed foods. Don't think that the medication is going to do all the work. The medication, you still have to go to the supermarket and shop and make sure that there are healthy alternatives in your refrigerator. So healthy snacks, so that you don't find that you're at work and you get sort of hungry at 3-4 o'clock, and the next thing you know, you're going down to the donut cart or something. So there's work. The other thing is planning. If you leave things to chance or the last minute, invariably you may not be making the best decisions for yourself. So you need to plan meals, you need to plan for snacks, you need to plan if you're traveling, if you travel for business, try planning for that. The other things are, physical activity. And this has to also be individualized. I can't tell someone who really hasn't done exercise, well, now you have to exercise X minutes per day, this number of times per week, do, 900 reps of something with 10-pound weights. You need to know where you're starting from and then make changes. And there are techniques for making changes. They're called like SMART goals, okay? To try and be specific as possible, to find some measurable goal. So don't say, I'm going to exercise. Okay, you have to say, I am going to do this, and when you're going to do it. And this way you can determine, was that a good goal for me? If I didn't meet it, why didn't I meet it? Maybe I need to change the goal. Things like food logging, okay, to have an accurate assessment of what you're taking in, because a lot of calories go unaccounted for, and you may also not realize the calories that you're taking in. And if you food log at the end of the day, you say, wow, even if it's almonds, did I really need like that whole handful of almonds, or could I have, eaten 12 and been, fine with that? So these are incredibly important, even if the GLPs are working for you, you need to help them work.
Yeah, and to that, so lifestyle changes are really fundamental, even as Dr. Korner said, by using the medication, and to that, besides, of course, nutrition and physical activity, sleep, prioritizing sleep quality and duration, or management of the stress. When we are stressed, we tend to be some individuals tend to eat even more. So you have an imbalance of your hormone, cortisol goes up. So you can have changes in feeding behavior, and find sometimes I feel like having I think having a behavioral support, be part of group-based programs that can help you to maintain these healthy lifestyle changes can also be very important to achieve your goals.
Thank you. That was so well put. And I guess my last question for both of you before we give you some questions from the audience is, how would you recommend finding like the right professionals or a care team, to work with them, especially if an individual is thinking that they might have metabolic disorders, or they're trying to lose weight and they've tried everything under the sun? What would you recommend?
Yeah, so it really is important to find the right professional to help, uh, particularly someone who's able to work with you with regard to, advancing to using the medications, and someone who can help you deal with the side effects. I mean, Dr. Diano was talking about the nausea. I mean, there can be nausea, vomiting, diarrhea, constipation. Eh, you know, you can usually work through these things with good advice, as opposed to saying, I can't tolerate this medication and then stop it. So if you find that, maybe you're not getting enough advice or enough help, I mean, one of the things you can do is go onto the website, the American Board of Obesity Medicine, for example. I think you can put in like your zip code, and that will lead you to individuals who at least were board certified in obesity medicine, and they may have more experience and more knowledge. So I would, try that. Certainly try working with a nutritionist or a dietitian. Sometimes that's problematic because that's not always covered by insurance, but to at least look into it. So I would say, yeah, try and get experienced help.
Absolutely. So I have, and Angela, if you want to ask any particular questions from our audience
Yes,
members.
I have several questions in the chat. Can you address perimenopausal / menopausal changes and their impact on metabolism / type 2 diabetes? And they list other things like cardiovascular.
Mm-hmm. Yeah, so that's a difficult time, perimenopause, menopause, women will, even if they don't gain weight, they'll say, I don't know what's happened to my body. I used to have a curve and now I'm like a rectangle or a square. Um, there's sort of fat redistribution, and some of that can occur more in the midsection. That can be accompanied with, some insulin resistance, increased risk for heart disease. And some of that it's just the natural way of aging, and we can't really combat that. I mean, it's not necessarily recommended to go on hormonal therapy just to try and prevent that. If you need it for other symptoms, sure, absolutely. But yeah, some of that, happens with aging, and then it really does become more important to become physically active, do the weight training exercises that will help prevent against some bone loss, because we start worrying about things like osteopenia, osteoporosis. Make sure you're getting enough calcium and vitamin D, that you're getting proper sleep, that you don't have night sweats that are waking you up in the middle of the night. You may need treatment for that. So it is important to, try and address at least some of the symptoms that are addressable in the perimenopause, menopausal state.
If I can add to that, it's a very physiological, if you will, mechanism that are occurring in perimenopausal and menopausal period, which is a decrease in our estrogen and our gonadal hormone. And these are important, actually, metabolic hormone as well. They do act in the brain as well and regulating all the same function that, for example, GLP-1 regulate. And so the lack of estrogen in menopause will have a profound effect on our metabolism. That's why our metabolism changes. And of course, estrogen also affect many other organs, including the bone. So this is, it's actually, there is a very strong physiological, processes that they are occurring during menopause that induce this change in our metabolism.
Thank you. Another question, how would you know if and when you should switch brands? I'm guessing from like Wegovy to Zepbound.
Right. Well, if what you're taking is working for you, there's no real reason to switch. If you've lost the weight that you need to lose, want to lose, and you're not having side effects, then don't switch. Overall, in clinical studies, Zepbound or tirzepatide, in general, is associated with more weight loss. In my experience, it's also associated with fewer gastrointestinal side effects. So then it may be a good idea to think about switching. Unfortunately, and I see there's a question in the chat about insurance coverage, a lot of what we decide to do isn't of our own decision, but it's dictated by insurance. So you, for example, may want to switch over to Zepbound, but your insurance might only cover Wegovy. You try and make the best choice possible, but sometimes, it's not possible.
Somebody asked if you could take metformin while on GLP-1s.
Yeah, they can be taken together. The two together won't lower your blood sugar to dangerous levels. Where you do have to be careful is if you are taking insulin, for diabetes, that your blood sugar may go lower, in which case you might have to work with your healthcare provider about changing your insulin dose levels.
Can you please comment on BMI in children and adolescents? They are growing. How reliable is BMI in children?
Yeah, a different measure is generally used other than BMI. It goes by percentile compared to children of their in their age, and it goes by height to weight, and so it's sort of different parameters. But yes, you have to know that someone who may be chubby, earlier on will then go through puberty and there's this growth spurt and they become a string bean, it has other parameters that are used.
Okay, this could probably be answered. It says, what are your thoughts on staggering the doses from every 7 days to every 10 to 14 days if you have reached your optimal weight? And another one was about microdosing. Do you have an opinion on microdosing?
Sure. Well, once you reach a stable weight, a few things, you can decrease the dose and see what happens. You can try every other week. One of the reasons to do that is, let's say you're paying a high copay or paying out of pocket. The less you take, the less out of pocket, you'll have to pay. That hasn't been, studied necessarily in any formal way, but you can change those schedules or change the dose. Microdosing, it's unclear even what that generally means. It's usually, people taking lower doses than what is generally prescribed. But in order to microdose, usually you may have to use a compounded version. You can't microdose if something is in an automatic like pen. You have to take it like from a vial. And there's a question whether those compounded versions of these drugs are safe if they're not FDA approved medications from a known pharmaceutical company. Where I would see microdosing or using lower doses than generally accepted is if you are very, very sensitive to the medication and are having side effects. There are some pens where you can use lower doses by counting the number of clicks that you use. That can sort of be a so-called microdose. But I would beware of, why does someone have to microdose? Are they losing too much weight? Should they not be on the medication to begin with? So it's really more something that's out there in the media as opposed to something that we really do clinically.
Okay, I think we're at time, but we could probably just have one more question. And then if you have additional questions, you can send an email to hrbenefits@columbia.edu. We will compile the questions and get the answers to you. But just one last one. Can you discuss the effects of taking hormone replacement therapies and GLP-1? What studies have been conducted on women taking both, and what are the concerns one should be aware of?
Yeah, I'm not aware of, any specific studies, that parse that out. Certainly the clinical studies have included postmenopause women who are postmenopausal, and some are on hormone replacement. There's a question here, can you take it with breast cancer prevention, tamoxifen, anti-estrogens? There's no reason why you shouldn't be able to do that. There's no study that I am aware of that these medications don't work as well if you're on hormone replacement, or do they work better? So I would just say it's totally fine, to take these medications together.
Just, I guess, to end on one of these ones, is it okay to have a glass of wine?
Yes, it's absolutely okay. Having said that, and I know we're out of time, but interestingly enough, these medications are often associated with a decreased desire to drink. It's incredibly interesting. They may be reaching certain areas of the brain that are involved in the desire to drink. And I'm not talking, in the setting of overuse of alcohol, but even someone who might have a glass of wine, with most nights with dinner. Some patients report they just don't feel like it. But yes, you can have a glass of wine every now and then. You could have a piece of birthday cake every now and then. You can certainly have enjoyable foods, but not in excess.
Yes.
Thank you both so much. I do want to say that up here on our screen, we have a playback of today's presentation and of our panelists, and also check out the website because we'll also have additional resources on what Columbia offers for individuals that are surrounding weight management, especially like our medical plan does cover registered dietitians. So with all of that said, thank you both so much for taking the time to answer all of our questions here today. And I wish you and everyone else here that listened today a wonderful rest of your day. Stay safe.
Thank
Stay
you.
well,
Thank you.
everyone.
Thank you for having us.
Thank you.
Bye-bye.
Bye.
Bye-bye.